Okay, so for any of us who manage acute on chronic liver failure, or ACLF, you know that for years we've been relying on the EASL-CLF criteria. It's really been the gold standard all over the world for diagnosing this incredibly deadly syndrome and trying to predict outcomes in our sickest patients with cirrhosis. But as our understanding gets better, our tools have to get better too.
And that is exactly what is happening right now. A huge, and I mean landmark, global study just published in the Journal of Hepatology has developed and validated a major refinement to these criteria. It's called the A TANGO Score, and what it promises is pretty big. A more accurate diagnosis, better risk prediction, and honestly, a much more robust tool for the future of ACLF research.
So, to really understand why A TANGO is such a big deal, we've got to first take a look at the challenges we're facing with the current system. What were the specific limitations that made this massive undertaking so necessary in the first place?
And that's a totally fair question, right? I mean, the ESCL-CL-CLIF score has served us well for a while. But day-to-day clinical practice has really shown a spotlight on several key areas where it just falls short, creating ambiguity and, potentially leading us to misclassify patients.
Now, this slide really gets to the heart of the clinical pain points we all deal with. First off, diagnosing grade 1 hepatic encephalopathy, it's notoriously subjective, right? And that leads to inconsistent diagnoses. Then there's the INR cutoff for coagulation failure, which was probably too strict, meaning we were likely underdiagnosing coagulopathy. And this is a big one. The old ACLF grade 3 was just this massive, messy bucket, lumping patients with a 50% mortality risk right in with those at 90%. Critically, the score was also out of date with the latest nephrology consensus on AKI, and its predictive power could be thrown off by common therapies like GCF that mess with white blood cell counts.
So you see all these issues. They really created this urgent need for a better system. And that's where the A TANGO score comes in. It was designed from the ground up to address these exact gaps, and it was developed with an incredible amount of rigor.
So what is it, exactly? Well, at its core, A TANGO is a refined organ failure score, and it's trying to do three main things. 1, enhance the accuracy of how we diagnose ACLF. 2, improve how we stratify patients by their actual risk. And 3, and this might be the most important, give us a reliable and consistent tool for clinical trials, which we desperately need in this field.
And just look at the scale of this thing. We are not talking about a small study here. The score was built using a derivation cohort of almost 4,000 patients from Europe and Latin America. Then it was put through its paces in 2 huge and geographically distinct validation cohorts from India and China. So in total, this analysis included over 8,500 patients. That kind of global validation just gives these findings immense weight.
All right, let's get into the weeds. This is where we can really see how A TANGO recalibrates our thinking. We're going to go head-to-head and look at the actual changes for each organ system.
First up, the liver. Now, A TANGO actually raises the bilirubin threshold for organ failure up to 20. But, and this is the kicker, if your patient hits that single criterion, that's now sufficient to diagnose ACLF. This is a major change. Before, severe jaundice by itself wasn't enough. You needed another organ to fail. This new approach recognizes that profound jaundice is on its own a really powerful marker of the ACLF syndrome.
Now, for the kidney. The change here might look subtle, but believe me, it is clinically vital. A TANGO officially brings in the updated International Club of Ascites criteria for AKI. So now, meeting the criteria for AKI stage 1B or higher defines kidney failure. This is so important because it finally aligns hepatology with the current nephrology consensus, and it lets us identify and act on significant kidney injury much earlier.
And what about coagulation? Well, they've lowered the INR threshold from 2.5 down to 2.2. This directly tackles that problem we talked about earlier, where the criteria were just too stringent. This lower cutoff is much better calibrated to flag patients who have a 28-day mortality risk over 15%, making sure we don't miss these high-risk individuals.
Okay, the brain. A TANGO makes a really smart, practical change here. It basically acknowledges how challenging it is to diagnose grade 1 hepatic encephalopathy by lumping it in with grade 0. Simply put, mild confusion by itself doesn't count as organ failure anymore. For the brain to contribute to an ACLF diagnosis, it now needs to be paired with at least one other organ dysfunction, like a moderately elevated creatinine or bilirubin. This gives us a much more robust and clinically meaningful signal.
So those are the changes, but the real question is, do they actually work better? Well, let's take a look at the performance data because it is pretty compelling. And boom, here is the headline result.
Using A TANGO, the number of patients diagnosed with ACLF jumped from 24% to 36% in that first cohort. That is a 50% relative increase. That's a huge difference, capturing a big group of high-risk patients who were being missed before.
But this isn't just about diagnosing more people. It's about diagnosing the right people. The Net Reclassification Index, or NRI, improved by over 16%. Now, what that means in plain English is that A TANGO simply does a better job of correctly moving patients into higher or lower risk categories compared to the old score. It's just a more accurate risk model. And this chart? This just beautifully illustrates one of the smartest structural changes. A TANGO introduces a whole new ACLF grade 4. This completely solves that problem of the old messy grade 3 by carving out the absolute sickest patients. I mean, look at that beautiful stepwise increase in 28-day mortality with each grade. It gives us a much more granular and predictable prognosis.
And the really crucial thing? These impressive results weren't a one-off. They held up big time. In both the Indian and the Chinese validation cohorts, the NHRI showed significant improvement, and the score consistently diagnosed more cases of ACLF. And here's the key. This was all done with no loss of predictive accuracy. In other words, A TANGO is a more sensitive tool that's just as specific. It really is the best of both worlds.
So, okay, we've got all this data. What does it actually mean for us, on the front lines, in the ICU or the hepatology clinic? Well, the implications are pretty significant for both how we care for patients and for the future of research.
For anyone doing research, A TANGO is an absolute game changer. First, you get a more reliable diagnosis, which means a bigger pool of eligible patients for your trial. Second, because the score is so well calibrated, studies can be designed more efficiently, maybe even with smaller sample sizes. And third, it makes endpoints like ACLF resolution way more robust, which is absolutely critical for showing if a new therapy actually works. And it doesn't stop there. The study also developed 2 new prognostic scores. So just like the old CLIF-C ACLF score, there's a version that uses the white blood cell count. But, and this is really cool, there's also a new version that substitutes CRP for WBC. This is a huge innovation for any trial using therapies like GCS that artificially jack up the white count, because it means we can still accurately track prognosis in those patients.
In the end, the study's own conclusion really says it best. The A TANGO F score is a more accurate, reproducible, and comprehensive tool for diagnosing ACLF with well-maintained prognosticability, and it's been validated in large global cohorts.
And that really leaves us with this one big question to think about. By finally standardizing the diagnosis and giving us a much better framework for research, the A TANGO score might just be the key that unlocks progress. It gives us a clearer lens to view this devastating disease, which could very well mean we are on the cusp of a whole new era for developing and testing life-saving therapies.